A very good evening to one and all. Today's webinar is being arranged by IPWC Maharashtra, and today is their 50th webinar. So, congratulations, team. We are having a webinar today on research in clinics, that is, opportunities and challenges by Dr. John Solomon. The moderators for the session are Dr. Uttara, Dr. Priya Karande, Dr. Snehal Patel, and Dr. Nirali Sangvi. So over to the team.
Good evening, everyone. I'm honored and lucky to have the opportunity to give the introduction about the IPWC. IP Women Cell functions under the guidance of National Head Dr. Ruchi Vaishnav and IP President Executive Dr. Sanju Jhasa. We have 5 zones in India with heads for each. Dr. Pooja Kamble is the West Zone head. The state team of IPWC Maharashtra state includes Coordinator Dr. Suvarna Ganvir ma'am, Joint Coordinator Dr. Snehal Patel, and Sub-Coordinator Dr. Uttara Mohan, Dr. Priya Karande, and Nirali Sanghu. In Maharashtra, IPWC has conducted 48 low-cost activity today like CMEs, workshops, public awareness campaigns, health camps in various districts since 2018. We have also organized 58 webinars on topics such as PNF for trunk, NDT, kinetic chain activations technique, disability evaluations, spinal cord injuries, rehab, diabetic food, eye cheese, etc. We would appreciate your feedback on our webinars. Please submit your feedback on link provided at the end of this webinar. To know about upcoming IIP webinars, sync IIP events Google Calendar into your Gmail account. Today's webinar on research in clinics, opportunities and challenges is being conducted by IIP Women's Health Maharashtra State. Our resource person, Dr. John Solomon sir, is a MPT Neuroscience and the PhD holder. Is the senior associate professor at Manipal Academy of Higher Education. Dr. John Solomon sir is the chairperson of Institution Research Committee of MCHP and Mahe Manipal. He completed his master's degree specialization in neurological physiotherapy and PhD on virtual reality training for in coordination from Mahe in 2010. His research focus is on vestibular rehabilitation, motor control, virtual reality training, physical activity, and strategies to improve motor recovery after stroke. He has more than 19 years of teaching and clinical and research experience in neurological rehabilitation. He is member of various international working groups on stroke rehabilitation and at co-investigator on 3 international projects and leads 2 national funded projects. He has 42 peer-reviewed scientific publications to his credit. He is passionate about both teaching and research. During the webinar, if you have any queries or questions to ask the resource person, you may post them in the chat box. Thank you, sir. Sir, I welcome you. You can take over.
Thank you, Dr. Priya, for the introduction. I take this opportunity to thank the IAPWC's Maharashtra for giving me this opportunity to do this session. I thanks especially Dr. Uttara, Dr. Snehal Patel, Dr. Nirali, and as well as Dr. Priya for conducting this, being a panel members of this session. So I will start my presentation or the talk that I am planning to give today. So we'll have I'll have a talk for 45 minutes to a maximum of an hour, and then we will I'll take up the questions. This is a topic that is very dear to my heart, where there has been a lot of discussion, which is not on classes or in panel, but we talk about it a lot. How do we bring in clinicians into research? And so when Dr. Uttara contacted me, I readily agreed to take this topic. And I hope this is not like a teaching one. It's about probably giving you a few ideas or like facilitating certain triggers that probably at the end of the session you think, oh, probably this would is what would suit me, or this is what probably I should think about, or probably it won't suit me also. So I leave it to you. The end result will depend upon how you perceive it, whether it is a cup of your cup of tea or not. So, a few disclaimers before I begin my talk. I have no conflict of interest, and the suggestions that I put forth are my opinion, and the pictures that I use many are mostly from available freely from the internet. So, what is research? When we research is a process of systematic inquiry that entails collection of data, documentation of critical information, analysis and interpretation of the data, and from that you derive some information, okay, in accordance to the with suitable methodologies. So research usually starts with a question which is not answered yet. To answer that question, you go through this process where you're going to have a collection of data and documenting it properly and then analyzing it. And then while analyzing it, you find the answer to your question. Now, why should we research? Is it research important? Now, research drives knowledge or creates knowledge. Whatever we'll have learned, it cannot be just assumptions. Then in our profession, we cannot say that whatever we do is based on science. Okay, so the research brings in the science component, brings in new knowledge, and we as research progress, when we identify new treatments, new therapies, and evidence for that. So there is so if a particular treatment works or not, and when we know through a properly conducted research, then at the end of the research, if the if it clearly answers yes, it works or doesn't work, then you can decide whether this particular treatment can be given to the patient or not. So it basically drives the practice. The third important aspect is through research, new innovations come, new treatment strategies come, and only when you show those possibilities of effect of or effect of these treatment or strategies in patients, the scope of practice starts widening. Ideally, the research supports the professional practice. So hence, research is very important. And often in an academic institute, research is taken forefront in these days, especially because it is important for ranking of the institution and also research is highly facilitated in many of the institutions that are academic based. So the researchers in academic institution or pure researchers have a different mindset in which they work, and it's it's quite different from how a clinician perceive things. So I just wanted to discuss a few points. What are the basic differences between a researcher and a clinician? Sorry. For a researcher, the major intent is to answer a specific question through the research process. So it is not, so the process itself is about the research. Whereas for clinicians, as clinicians, we address the needs of individual patients. So clinicians are more, their focus is about patient wellness, and how this particular, what is good for this particular patient. So often the question behind the research aspects are subdued in a clinician. And when you look at intended benefit, the focus on benefit in clinicians are very high because they are their clients, they have come to them to become better. So the clinician usually takes up all the steps to make the patient feel better or benefit from the treatment. Whereas participants who come to a researcher, may or may not be benefited because they are participating in a research which basically is trying to produce new knowledge, and from that knowledge or science, it is generally the result of which will help in benefiting future patients. So it may not sometimes directly benefit sometimes in case of for the participants who come there. Researchers are supported by the granting agencies or institutions for doing the research, whereas clinicians, they are funded by the individual patient and their health plans. So it becomes very important for the clinician that they give the worth of the patient's money. So they cannot put them into anything other than what is best to them. Whereas a clinician, a researcher, has to, when they deliver intervention in research designs, they have to go as per the protocol. If this is the protocol, that is how the protocol has to be done. You cannot change your easily the protocol and modify according to people, according to the participants. Sometimes there are some designs where the intervention is also designed according to patient. In Whereas when you're a clinician, as a clinician, you take a real-time decision as to what should work for the patient, and so you go ahead with modifying the treatment or not. So if you generally, if you look at these 4 points, for a clinician, the focus is the benefit of the patient, whereas for a researcher, it is the answer to the research question. So that where a major difference lies between a researcher's approach as well as a clinician's approach. When it comes to consent and assessment, you can see that in researcher has to take a risk. These are the practical things. Written informed consent always. Clinician may or may not require an informed consent unless otherwise for a specific procedures. Whereas assessments also researchers do based on the protocol, specific time points. Whereas the clinician may do when the patient comes to the clinic on the follow-up on, there is no specific day. Sometimes you call them but they come on some other day, you have to take the assessment. So it's all patient driven when it comes to clinician. So there are two different mindsets. And clinician taking up the role of a researcher, it has to, they have to be careful that they don't leave out the interest of their clients. Okay, so that's extremely important. So that is why there are certain designs in which you need to, the clinicians involvement are limited sometimes, whereas researchers take up much more wider variety of designs. So in this case, if you're a clinician, who's should they participate in research? Now, who should participate? And shall everyone take up research? All clinicians take up research? I would say not really. Not every clinician has to do research. For a clinician, it is the patient's or client's benefit that comes first. Then comes next. Then research comes next. So if you are interested in research, you should take it up. So some clinicians are also interested in research. So they should find ways to get into research because of certain specific reasons, which as I go, I'll explain. Some of the clinicians are very curious and they are very intuitive to ask relevant questions. And these are clinicians who should uh, take up research, think about taking up research. If you are plainly those are clinicians who plainly go and give treatment, there that's different. But someone asking question, why am I doing this? Why is this different? Why each patient this patient reacts differently? What are the features? So you keep someone who is keeping on asking relevant questions should think about taking up research. Then usually clinicians are the first ones, such clinicians who are curious and relevant, asking relevant questions, are the ones who will identify a pattern that would often trigger the research question. So basic clinical research questions actually come from clinicians. So that's why it's important for such clinicians to get involved in research. So and along with that, those who have a habit of documenting outcomes carefully And those who are interested in writing and presenting should definitely think about participate, taking up research as one of their aspect of their profession along with their clinical service delivery. Now let's look at if you're talking about research, what type of research are we looking at? If you take a primary research, these research can be descriptive or analytical. When it comes to descriptive studies, they are surveys or qualitative studies. Where in so this is one area where definitely clinicians also should think about taking up. The other area is analytical research, which includes experimental design and observational and analytical design. When you take experimental design, it includes all the clinical trial kind of things, randomized control trial, crossover trials, and others. The other type of studies include cross-sectional study designs, cohort study, case control study. So, if you ask me, when you look at it as a clinician perspective, the next aspect of type of studies clinician could actually focus on, and they have a strength in, which are the observational analytical studies. And probably I will talk about what are the issues related to the experimental design at the end, but we'll think about which are the type of research someone can take up. The second thing is, these are primary research. The secondary research is research on research, that is already published article. Based on that, you do reviews, and here you have scoping review, systematic review, meta-analysis, which basically uses previous published data, and from that you are going to do the research. Now, these are some of primary and secondary research, and some of the areas where clinicians can also actively participate in research. Now, I'm going to talk about certain characteristics as points, and then tell if you are such a person, what type of studies you're going to take is good for you. For example, if a clinician says, I work in a setup where we get to see very unusual cases. There are certain centers which gets to see variety of cases very different from usually what is described in textbook or already described in journals. If you are looking at that, that is one setup. Second, if you are working in a setup that has access to new technology and intervention which are approved and are ready to be intervened on the patients, but it's very new, has not been really tested in our population. And if you are looking at, if you are working in such a setup, this is what it described you, then you should think about case reports and case series. Yesterday, we had a wonderful session on case report and case series. And I was saying that it's important, case reports and case series are also important research outputs that can initiate research questions. So case reports, if you take case reports, uh, it's a detailed report of individual patient, which includes their features, signs and symptoms, their progression, and how they responded to treatment, everything. Now you don't get you. It's not, but it's not like you report every case. Okay, you need to choose the right case. So it's usually case reports are used when there is a then you're going to recognize a new or a rare disease. For example, the present situation, COVID 19, we have no idea about the disease. It's still researchers are working on it, and so when you get different patterns, you need to report these cases. So that is one. Or if it is a rare case, not usually present across the world, and then you get to see that case. And how do you go about physiotherapy intervention in this patient? That case, you should, if you have done a good intervention based on scientific principles, and then you should then report it. Second thing is when you're evaluating novel intervention. It's pretty new, this therapy treatment, and we're not so sure about its effectiveness. But we know that this particular treatment could help this patient due to certain reasons, and you give that and then see how the patient responds, and then in that case you can report that case also. So usually case reports have a high sensitivity for detecting novelty, and that's why it's often sometimes considered as a cornerstone for medical progress. So many research questions arise from it. They don't give answers, but they give questions where looking at these reports. I'll just give you a few examples of published research that has happened already. As much as possible, I've taken studies that are conducted in India. Few I have taken from out elsewhere. Before that, so you are going to take the following steps. You need to identify the case as early as possible. Don't, oh, I should have reported this case. You shouldn't think when the time of discharge. Rather, if you identify the case early, what will happen is if you're documenting properly everything, you will not miss a case. Even if you realize it a few days later, you can go back and collect the data. So what you do is ensure that you identify the case early, get the team ready, the physician responsible, involve them, and then get all the possible data and follow up the patient. Remember to write also to publish a case report, you have to get the informed consent of the participant. Ensure that there is no identifiers that will reveal the identity of the participant, and write the case and then publish it. Okay. So there are quite a few journals that accept case reports. There are close to 40 uh, journals that are only reporting case reports in Scopus Index journals related to medical conditions. So, and there are a good number of journals other than the regular original research. They also have sections on case reports. So there are good scope for publishing case report in those journals as well. I'm just taking, as I told you, I'm taking a few examples. Now, for example, this is a case of spinal deformity, which is a musculoskeletal deformity related to the shoulder girdle, which is rare. That itself is a rare entity, but this patient has presented with a tethered cord syndrome because of the associated scoliosis and growth has resulted in a tethered cord syndrome. So it's really rare. So how do you deal with such a patient? How do you work on rehabilitating a patient? So the authors have gone ahead and discussed this presentation differently and in a conservative way, how they worked on improving the muscle power and functions of the patient. So so this is something rare case. So if you have a rare case like this and you're dealing with it, you can write it as a case report. Or you're thinking of something, a novel treatment, as I told you. For example, this was a case, this is a article that picked up my attention. They have done a study on improving tongue strength rehabilitation using biofeedback. So it's a they have used a device which can be used in the fitted in the mouth, and using the tongue movements like a joystick, you can they were training the patients to control a computer-based game, giving the biofeedback. So they wanted to look at whether such a training would result in a particular patient with who had tongue muscle weakness. So usually, again, biofeedback was never tried in such a condition in this way. It's a novel treatment. So then, when you do that and how the patient responded to that could be reported as a case. So it can be a rare case or a novel treatment. Or sometimes you come across cases that are common, but it is a combination of two diseases or disorders which is not usually present together. For example, this is a case report from CMC Velu, which talks about a paraplegia who also had a transtibial amputation. So they had trained this patient using both an orthosis as well as a prosthesis, and how a patient who is having amputation as well as a paraplegia can be trained for walking. They had measured the using the walking index for spinal cord injury, how the patient out of a total of 20 scores moved from 0 to 12. So they have, so that's a very nice way of giving interpretation for using a case. You can't you do a RCT in such case. You're not going to have similar cases like this. So these are cases that can be reported as case report and can be published. Okay, that is one aspect. The second type, this is again something that I told about yesterday as well. So when you write well in terms of including all the items that has to be presented in the case report. So a care checklist is a care report guidelines which you can use for reporting case reports. So you ensure you follow this reporting guidelines. So in that case, you won't miss any important points. Then the chance of it to get published is very high. So the next one is case series. Case series are a collective case reports kind of thing where you have more than one patient and who have undergone a similar diagnosis or similar treatment over a certain period of time. So usually, other than this could be reporting the nature of a rare disease in certain group of patients. For example, there were case series on Friedreich's ataxia showing progression after a particular intervention, exercise-based intervention. So there were 3 to 4 cases like that reported like that. Or if there is a feasibility of a new type of treatment which is trialed in more than one patient to check whether it is feasible to implement in all type of patients, then these can be written as a case series. Usually case series helps to develop hypothesis. So so that is at the end of case series, you kind of, okay, it looks like this might work, this may work. Then the research question, the hypothesis is that a particular intervention could work in this type of population. And with that hypothesis, you can go to the next level with a controlled trial to prove the hypothesis. That's the next level. But case series generally helps you basically to develop that hypothesis. There are many case series that has been also published. So I just took one example. For example, immediate effect acapella on ARDS, immediate on patients who were mechanically ventilated. They had reported 5 cases. So remember that. Also remember, if there are patients more than 3, if you're including, that requires ethical clearance. And if it is less than that, 3 patients, individual informed consents also could be adequate. But otherwise, you need a ethical clearance. Now, other thing, for example, this is as I told you, like to check feasibility. This is a study where they looked at a robot-assisted training, which is in subacute stroke patients that has been used now in quite a few developing countries, and they're trying it. But one of the issue is that the therapists have also do a lot of has to be with the patient, and you also trigger a lot of settings. So they wanted to try whether caregivers can be trained to use these robot assisted training. So that was a study that where they looked at 6 patients, I think, to see whether such a thing is feasible. So they came up with certain issues that were there, and then they had said these things are addressed. Possibly, it could be treated. You can probably use caregivers for training patients using robot-assisted training as well. So this is like one example of it. So wherever feasibility is there, and also one more thing. If there are novel treatments and initial feasibility studies includes even adverse event reporting. So it could be sometimes helpful to identify caregivers using caregivers. Does it increase the chances of falls or any other risks? So if it is so, that should also be reported in the case series. So that gives also the information what you have to be careful about. So these are some of the points that has to be used as a case series design. So that's how those who are in working with unusual cases, novel treatment techniques, I think should think about case reports and case series. The second type of clinicians who say that my work basically involves a lot of screening large number of clients. So there are people who work in hospital settings and other settings where you do a lot of documentation and screening of large number of clients, and you store these documents safely. The second, they also say that they have contacted large number of people, patient population that's coming in. Second, they say that I have a good network of both patient population, or I say they have a good network of professionals. So this is about where you have a good connect with a large number of people. If you are a person like that, if you're a clinician like that, then you should think about like cross-sectional studies. Okay, it could be surveys. For example, a cross-sectional study basically involves taking up in a large population, taking up a small sample and gather the data at that particular time, and then decide what is the characteristics. For example, in the present situation, again, if you take, if there are many patients, many people are tested for COVID, say how many are tested positive and how many are not tested positive. That is the first level, exposure level. Second, how many of them, those who are tested positive at the time of tested positive, do have respiratory problem, and those who do not have a respiratory problem. So if you see, this data is already being collected and published. So this is just for an example. So like that, cross-sectional observational studies or they data that are collected at a population at a single point of time to identify the nature of the disorder and looking at certain association. You will come across studies that are often cross-sectional surveys like this. For example, prevalence studies. In a particular condition, what is the prevalence of certain things? For example, if you are a clinician who treats a lot of neck pain, uh, a chronic neck pain patients, how many patients, what is the prevalence of neural affection in the chronic patients, chronic neck pain patients? It's also, that itself is a prevalence study. Okay, so if you have a large population of patients coming in, you keep asking questions or identifying the problem and then report the prevalence. Or when you're looking at certain association, you take up certain questionnaire and develop, identify different things such as age, BMI, um, work, socioeconomic factors, and then you look at disability and see which one associates most for a particular problem and what is the burden that they have. Such studies as you can conduct in a cross-sectional survey. Knowledge, attitude, and perception of people. This is one of the things that is picking up recently to identify how people are aware of things. What's their attitude towards certain things? For example, what's the knowledge, attitude, and perception of physiotherapists to be involved in COVID-19 management? How many of them know the guidelines how to treat a COVID-19 patients? How many of them are willing to do so? And what are the risks they think is there? Kind of things. No, those are some of the type of studies. And practice. What is the present practice? For example, how many clinicians across India do follow evidence-based practice? As simple as that. Could be a simple question-based thing. So identify practice across professions, or just an opinion. Okay, even that sometimes could be done as a cross-sectional survey. So survey is another form of study, and especially is very good if you have a good network of either patient population or professional network population. Then you can conduct such studies to get the idea about what is the present situation of prevalence or knowledge and attitude or practice in about a particular thing. Just for example, I put okay, yeah. So basic steps. Sorry, the basic steps. Always decide the population on whom you're going to do the survey. Decide the question, thing that you are. What is the survey is going to be about, and what type of survey you're going to do. Whether you're going to do an online survey or a paper-based survey. Then frame clear questionnaire that has questions that have relevant to that particular survey. Don't put too many questions. Don't keep identifiers. This is one of the things I would like to point out here. I get a lot of surveys sometimes that comes through professional networks. They ask about your name, your email ID or your age, your certain, so your phone number. Now, see, these are things you need not collect if it is not relevant for the particular thing. So you are identifying them. So ideally, a research questionnaire should not have such direct identifiers. So frame a good questionnaire, check for its validity, and get the approval. Most ethics committees will look for identifiers. So if there are no identifiers and it's a good validated questionnaire, then circulate to the right sample and then collect the data to get and analyze and write the report. Once you have a clear analysis and what you know the percentages in frequency, how many have this, how many have that, then you write it and publish it. Okay. For example, one of the studies that we did was a few years back was we wanted to look at what were the facilitators and barriers for using neurological outcome measures. So this study was done as a cross-sectional study both in India as well as in Canada, and we wanted to look at how therapists in India and Canada differ and what they tell us the major barriers or facilitators for them to use standard neurological outcome measures. So you can ask like that, that was a question that we addressed. What are the barriers? What are the facilities? Why do you use it or why you don't use it? And that will give us an idea in what direction we should go next. How to solve this problem if they are not using an outcome measure. If you say the major problem is unavailability of the measures. Now, for example, there is a repository being started for example, in IFNA, Indian Federation of Neurorehabilitation, where all the tools will be put, or make them aware of repositories where they can get the standard tools. So that will give you a solution like that. So that's about those people who have good connect. Now, the third group, you may be in all the groups, but I'm telling you, depending upon the characteristic. If you say, I have a large, good quality patient data, every patient app that has come to me, I document. I take standard measurements. I store it safely. Or you say, I have a good client load who have a very good follow up. I have follow ups with clients like 2 years, 3 years, 5 years. I regularly follow up with them and have documented their progress. So if you are a person who has a capacity or has already a good capacity of large patient data, I'll tell you that's a big asset for a clinician for research. Mostly all research depend on data. So if you have good, large, uh, standard uh, data you obtained using good outcome measures and stored properly where you can go back and check it easily, then that is your asset. Okay, so in those studies, you can look at studies that are retrospective and some of the studies that are prospective observational studies. For example, say, for example, a case control study. So case control studies are those where you at the end you see that there are two existing groups differing in outcome. One group improves, one group is not improving. Okay, and they are compared on the basis of some supposed causal factor. So imagine a group of patients who have come to you, and then for example OANE, there is a group of patients that did improve, there is a group of patients who do not improve. Then you think, why is that a group of patients are not improving? So the question in my mind would be that, is it because their predominantly their BMI had never changed. Those who did not lose their weight, they have had a weight, they didn't have weight loss, or there is no change in weight, or they have a higher BMI. Is that the reason why they are not improving? So what you do, you go back. You have a group that improved, that did not improve, and go back and look at the BMI factor in both the groups and see whether that was a factor. Okay, so it's often retrospective. So you go back and compare between the two groups. Those who had higher BMIs are the one who are not improving in knee pain, or those who are with are another factor. Those who came with higher BMI but had a good weight loss over a particular period of time are the ones who improve with knee pain. So that gives you an idea. So then you can report. So this is the factor that we think are when we went back to our data, we compared 100 patients, those who improved, those 100 patients who did not improve, and we looked at the factors and identified that these are the major factor that influence their outcome. Okay, so that is just based on the data that you already have with you. So it's a good study that gives you an idea. So you know what you should target in patients afterwards to even manage those cases. This was just an example. This was a particular case control study that looked at fat pad thickness of plantar heel pain. So they found that those who have thinner ones had a higher heel pain, and though they had taken longer time for the recovery to happen. So you understand the chances prognosis of these patients, and so those who had a lesser fat pad thickness, then you need to expect a slower recovery. The second set is related to the cohort studies. Cohort studies are more prospective. You're looking at a group of patients where they are you're taking up, and it's not only prospective, it can be retrospective also, but majority of the time it kind of you take a large population of individuals, record their exposure, follow them up for over a period of time, and see what has happened. Okay, it's over a time, and this can happen till the exposure is there, or it can even happen after a long time, after a follow-up period, at the end of the period. So usually you have a people who have exposure, and then at the end you have what has changed that has happened. So in clinical setups, for example, here the exposure could even be a treatment. For example, a group of patients who have undergone a weight loss program, it's saying that come for a fitness program, had come for an 8-week program. So they lost weight, they are losing weight at the end of 8 weeks. Then they go back, their program is over. Now what happens to this cohort over a period of time? Say at the end of 3 months, is the weight loss still maintained, or they have started putting on weight? What happens after a year? As their risk for NCDs come down, all those things can be checked with the group also that probably was there with your clinic at that time, but did not possibly partake in the weight reduction program, but they had generally come for other treatment. They were not a part of it, and then follow up them also and see whether the group of interest or the group that took up the weight loss program had reduction in risk factors, whether the weight loss was maintained, and those kind of things compared to another group. So it's a follow-up study. There are cohort studies that has run for years together. There are national cohorts that run for 50 years, 60 years, also following a patient or people and seeing their characteristics. But we can do short cohorts also, as small as 3 months to 12 months also. So, for example, this was a cohort that was done on physical activity and incidence of diabetes in American Indians, and it was done they had looked at physical activity levels, and they had followed up for a period of 10 years, and then they have found that those who reported being physically activity had a lower risk of developing diabetes. So, such a thing, for example, could be a cohort study. So you can also start cohorts. You identify cohorts, the large group that you have with you, and follow them up and see what is the outcome of these patients over a period of time. But basically, this involves regular documentation of various things. Maybe it could be just documenting their weight or general characteristics to taking disability kind of thing that is repeatedly done over a period of time. So that's for those who have cohort studies. Now, you say that, okay, I'm a person, I'm a people person. Patients are very comfortable talking to me, I'm a good listener and I have good interviewing skills. Or you say that if I have a strong logic and I can generate concepts that's on based on systematic observation. If you are that type of person who's a people person, like to talk, not you talk too much. You have to be a good listener first, and you have good interviewing skills. Then the other option that you should think of taking up as a research is a qualitative research. Now, qualitative research is different from quantitative research. Is that in the way that you are not looking at the data collected quantitatively, like what we saw till now, like in the case control study or cohort studies, and other studies where standard outcome measures are used, and you're looking at the change, you're looking at numbers. But qualitative research is not that. Qualitative research is often involves non-numerical data. It's about what a person's perception is, what they actually have problem with. So usually qualitative research helps to understand concepts, opinions, and experience. And these are also very important form of research because it gives um, insight to in-depth problems, and from there new ideas for research get generated. So by interviewing, you elicit certain factors or uh, things that are associated with particular population, and from there you know, okay, these are the factors or things that seems to influence certain things. Okay, there are various designs when it comes to qualitative research design. The most common ones are in the top one, that top two one, that is the in-depth interviews and focus group discussions, among all the other as well as other important designs as well. So why the top two is what I would like to focus on, is because the type of put in a clinic, you after hours, after you're finished, you can probably, once the patient is finished, if they are willing to partake, you can conduct a in-depth face-to-face interview. Or if you are conducting a wellness program, and if there is a group of people who are doing it, or they have come together, you have a group, then you can have a focus group discussion and elicit those things. So usually the steps involve first identifying a clear qualitative question. Qualitative questions are different from quantitative questions. This is more about exploring the ideas of patient, or what could be the underlying factor why a person is ready to do exercise or not to do exercise. What are the factors, or as a person? So you look at much more in depth. So you need, for example, you identify a question, qualitative question, identify the population that you're going to interview them, and then you have to decide on the type of interview, whether it is in-depth face-to-face interview or a focus group discussion. And then you have to develop a guide. It's like a questionnaire, but it has a guide. It's a certain questions, and then it has probes that you can use to ask question and take more and more in-depth interview with the patient. So once you develop it, you validate this interview guide with experts, get the approvals. If this also requires ethical clearance, get the approvals, and then once you know, you identify participants, and then start doing the interviews. Now, these interviews can extend time 30 minutes to 1.5 hours per person. Each interview has to be transcribed the speech into words. So everything has to be typed again after listening to the interview. Sit and type. It takes a bit of time to do that. And then you have to individually statements, you have to identify, code it. This statement belongs to an emotional thing, and it involves an environmental factor. Like that, you have to identify multiple codes, and then from there you are going to generate themes that are gives you the new themes. What are the factors, or what are the things that is influencing? Now, this requires both training and time. there are quite a few training programs that are conducted in institutions, and there are a few online training programs that talks about how to do qualitative research. There are online courses that you can take up. The thing is, it consumes time to do the interview, to transcribe the speech code, and right. So you need to have patience. You need to have time to do it. So this is one of our study that we published. PhD, presented a student who is also a principal in Oxford Physiotherapy College. Now we look where his work was in looking at how the context influences use of arm. What are the things that influences the person with stroke or hemiparasis use their arm for function? And we did a in-depth interview and developed some themes and things, and that also such things can be published. Now, you are not much of a talker or a listener, but imagine you are a person who loves reading. I think that you are you say I'm not like that, but I'm a very avid reader. I love reading scientific articles. I love critically analyzing these studies. When I read, I think about it. How is it? How is that? There seems to be some problem or whatever. You enjoy reading scientific articles. If you are such a person, then you should think about secondary research rather than primary research, such as systematic review or meta-analysis. So systematic review and meta-analysis are the highest level of evidence level. So these studies are considered of a high quality and high level of evidence, and has to be done really well. The one thing is that you should remember, when you start doing systematic review, you can't do it alone. You need at least minimum one more person to do an independent search with you, and preferably I would always say a minimum of three people. The third person, usually the conflict manager, someone who will consult with both of them. But you need to find another person with your same thought process, who will be ready to work with you, and then you can start out with a systematic review. So a systematic review usually answers a defined research question by collecting and summarizing all empirical evidence that fits pre-specified eligibility criteria. So it's not just reviewing all articles. You are setting a specific criteria under, for example, what is called as PICO. What is the population? In which population? I, intervention. What is the intervention that is here, that is going to be given? See what comparison they have done with controls or with the regular therapy, and what outcome. So, for example, what is the effect of manual therapy on patients with chronic back pain? So, on pain or numerical pain scale, has it come down or has it reduced, improved functional mobility? So, you need to clearly define the question, define your outcomes, and then do a systematic search by which you can identify what is the level of evidence. If you have enough articles that could have data from where you can extract data, then you can also do a meta-analysis that looks at what is the change in each study, how much change they have reported in mean compared to control, and whether that favors the control group or the experimental group, how much is the change. And you collect that data and summarize it, what is called as a forest plot, and then give a level of evidence for that particular treatment. So, as basic steps in systematic review: define your research question clearly, write a protocol how you're going to do it, which includes where you're going to search, what keywords that you're going to use, all that, and then register in one of the sites. For example, Prospero is a site where we usually register systematic reviews. Build a clear search strategy. Actually, build search strategy comes with the protocol. You give the exact where all you're going to search, what are the type of keywords that you're going to use, run the search in those databases, identify all the articles, remove duplicates, screen, collect, finally get the set of articles that you can, from where you will extract the data from each article, and then either, if possible, you do a meta-analysis. Otherwise, you are going to synthesis what is the evidence reported and critically write about it, and then in tabular form. So that would also be one of the ways to go about when you're doing taking up research. So this is that you can do it in your evenings, free time. One of the challenges that you need access to databases. The PubMed is a free one where database that you can do a search on. But if you're looking at other databases like Scopus or Web of Science or Embase, these are databases where the journals are listed and articles are uploaded listed, where you can use the keywords and do the search. Most of the institutions will have access to it. So usually it is good to collaborate with an academician to do these searches. And also this also requires training and time. Okay, so usually you take up at least an online course on systematic review and meta-analysis, learn the steps and then proceed with it. So this is one of again our study on systematic review and meta-analysis done by Amreen, who is my PhD student. Again, we looked at the effect of TENS on spasticity in patients with stroke, which we published in APMR. So this was again to look at what are the parameters that are used, which is useful, how much. So finally, in which parameters seems to the spasticity seems to reduce. So we systematically analyze the articles and talking about experimental design. Now, as I told you, going back to the first difference between a clinician and a researcher. A clinician's interest is on the client, should be on the client, it should not change. Okay? Experimental designs invite participants to take part in an experiment which could put them into a new intervention which may have risks. It may put them into a group that does not receive treatment. So many things. Okay. So there are designs which are basically single group, pre-post design, randomized crossover trial or not randomized trials or randomized control. All of the experimental design has either some form of risk. So there are a lot of ethical issues involved in it. Okay. So if you take a, for example, in any study, not just the experimental study, including qualitative research or surveys, participant safety is the most important one. At least in those studies, it's very, very less, like process survey studies and all, there is hardly any, except for the identification issues and qualitative research in terms they go into kind of they realize a problem and they go into depression. Those are some ethical issues. Whereas in experimental design, it's even more higher. Okay, there is more than minimal risk. So patient participant safety is most important when it comes to participating. It has to be a voluntary participation. You can't ask your clinic patient to come on, you participate in this study. Like that, you cannot force. Hey, you can tell about there is a study going on. Would you like to participate in the study? It should be a voluntary participation. And remember, once they participate in such experimental design, they are not they should not bear any cost in participating in the study. All interventions has to be given to them for free. Anything that involves the study has to be for free for them. Even if they have to come for the clinic to take the intervention because of for that study, their travel, their refreshment has to be arranged by the investigator. And if there is any adverse event because participating, test reporter committee who will look at the chances of risk, what has happened, is it because of participating in the study, and if it is because of how much, what are the problems the patient has faced because of participating in the study, and for what would be the compensation. All these things are involved. So there is that's why such experimental designs preferably should be done with research funds which supports all this. And there should be an ethical committee or a safety monitoring committee that looks at patient safety. So that's why doing an experimental design in a clinic alone is not usually advisable. Usually it's done, and that's why an educational or education research institute which has an ethical committee and can support these aspects. So does that mean a clinician can't participate in clinical trials? Not really like that. You just have to be dealing it differently. So you can collaborate with a research institution and join a larger trial which is already funded. Okay, so you can be a recruiting center. So, but you have to follow all the things. So you once you recruit the center patient participant in your center, and if you are delivering the intervention, you also have to follow all the protocols as per the research thing. You cannot deviate from it and say, I think along with that, if I give this more, the patient will benefit because my client, I can do more. You can't do that. You have to stick to the protocol, and you have to sometimes remain blinded. And all the things of the participant will be supported, should be supported by the thing. And you, the patient, your clients may not have a direct benefit. Okay? You should remember that. But with that, but still you can collaborate and then initiate clinical trials as well from your side. That's why a collaboration between a researcher and a clinician is very important, because it helps you to form good research designs. Getting the approvals in from the institutions is possible. Fundings are transferred. Funding agencies will fund those institutions that has the administrative support to handle the funds, has an ethical committee, has a research support. Then the funds are coming. So if you collaborate with them, and they can also help you in write up. So in terms of clinical experimental design, I would say always go ahead with that type of collaboration and do. Not only that, but in the initial stages, it's always good to collaborate with researchers for the learning purpose. Okay? So my suggestions at the end was that as clinicians, it's important. You are the people who will identify the most of the research questions. So it is good you participate in research and take certain necessary training wherever required to conduct a basic research, or if it is a little advanced or a specific research or qualitative research or systematic review, take those trainings and then you do it. You should do it. And you start with one small study. Dedicate your time and effort. Collaborate with someone who knows already about it, or find a mentor who can help you doing it. Spend your time, do the research well, analyze the result. Just don't stop in finally doing a conference presentation, but also publishing it in a good journal. And you will see your reward. At the end, when you have already done a good research and published it, it becomes a history. It's like your name is imprinted for history. Anyone who later comes to write about, do research, may quote you. Your work is being cited. So that is the uh, uh, final thing that you get. It's like you make history. So I would again take interest in participating in research, and I wish all of you the best to take up and do good research as well. So again, my acknowledgements to the IAPWC Maharashtra, and my institution has been supporting my research, my mentors and colleagues, and my PhD students who are all responsible for the research work that we produce from our center. Thank you.
Thank you, sir. It was very wonderful session with the research related. So I would like to ask you some of the few questions by the participants. What is the practicality of conducting research in a clinical setup, considering there is a lack of large patient data and the lack of support staff and students?
Okay. Yeah, that's true. That's a practical thing. So, if there are not large patient data, there's always clinical networks that can be initiated. More than one clinic can join together. So, there are multiple clinics that come together and form a small network for that particular study. And then ensuring that all these clinics have similar way of collecting data, then it becomes a larger one. In terms of collecting data, yes, agreed. Um, you need extra time to look at it, to collect the data. Otherwise, you have to find funds to support the person who might have to collect the data. So That's where I said it's good to associate with one of the academic centers. So in that case, they may either they can get the funds or they can a lot of person or a student who can come there and collect data, and you become a part of the study as well, starting from designing the study and planning and doing until the publication. That is one way of outreach.
Uh, while working in an independent clinician, if attached to a private hospital, where and how do we seek the ethical clearance and other permission needed for the research?
Okay, so usually many hospitals, private hospitals may not have an ethical committee unless they are regular research. But there are independent research committees that will be there in the cities that would take up ethical clearance thing. But usually the problem with that is that they are expensive. You have to pay the ethical committee fee for that clearance. Otherwise, again, you have to go associate yourself with an academic institution. Otherwise, this is the way. You have to identify an independent ethics committee that is taking up projects in that city or so, and then do that is one. And you need permission anyway from your the hospital in charge or the one who handles the data. So permission from there and ethical clearance from an independent ethics committee will be required for you to do the conduct the study.
Can you please comment on a publication issue with the genuinity of the journals?
Okay, so it as you know, there are predatory journals, what is called as predatory journals, which just take money and publish. So the first thing is that if they say that you as you submit, you just pay me some amount of money, within few days we will publish it. That kind of people, stay away from them. Then your credentials will go away. So do not publish in that. There are lists that possibility that these could be the predatory journals. But more than that, rather looking at what is not good, it is good to look at what is good. So if you take, for example, Web of Science database or Scopus database, they give you certain scores. For example, there is something called as impact factor, or what is called as in Scopus and Web of Science, they divide journals into quartiles. Top rank the journals in that particular subject, and they say this is in the top 70, I mean above 75, 75 to 50, 50 to 50 and below. So those that are there in the quartile 1 and 2, that is the above the 50% mark, they are all good journals, and they have a usually a very good peer review process, and then they can publish it. They publish good. So that's how you find authentic studies, authentic journals where you can publish and stay away from predatory journals. Definitely.
One last question. Why do we need more than one person to conduct a systematic reviews and meta-analysis?
Yeah, so because one of the process is that the two people have to do independent search with the keywords. It's not that because it's possible that when one person do the search, there is a possibility that you might miss a few articles when you're either doing the search or while doing the screening. So that's why another person is also needed who will also do the same process. And at the end, you have to see whether you have collected all the both of you have collected all the articles or not. And then when you screen, there should be an agreement. It should not be that your own opinion that this is a relevant study. Another person also should feel that this is a relevant study. So you kind of say, yes, this study should be included for my review. This study should be included for my review. Like that, you choose same way the other person based on the criteria, and then you compare, and then you see that out of say, imagine there are 10 studies, and then 7 studies you are agreeing both, and there are 3 studies from yours that the other person has not ticked as should be included, and that's where the third person comes. That person is a neutral person who looks at only the objective of the research question and says whether it should be included or not included. Then he becomes like a judge, and they said, okay, include this study, don't include this study. Then you have the finalist. This is to ensure there is no bias from one person. You can't decide that I will decide these are the relevant studies. There should be some way where you take out that selection bias, and that's why you need one other person. Okay.
Okay. Thank you so much, sir. It was wonderful session with you. I would like to now, sir, to please announce the winner for the yesterday's competition. Dr. Uttara, are you ready?
Yes.
Okay.
Just a minute.
Okay.
Okay. So can you let me know when I can announce?
Uttara will
Yes.
tell you.
Yes, sir. So we have a competition on case report and series are organized by IP Women's and Maharashtra State. So 5 finalists presented their cases yesterday with judges Dr. John Solomon, Dr. Suvarna Ganvir, and Dr. Nehal Shah. So these are the winners for the competition. If you kindly announce it.
Okay. So the third prize goes to Akila Natation. Congratulations, Akila. Second place winner is Dr. Gayatri Srinivas Jere. The second place winner. Congratulations, Gayatri. The first place goes to Dr. Anaga Nitin Mangonkar. Congratulations, Anaga, and congratulations to all the participants. Actually, all the session, all the 5 were really, really good. It was a matter of few marks that differentiated based on just a minor things. So keep up the good work, all of you. And I would now also tell that all of you try to publish this. Okay, now this is the time you can also try to now write it neatly and try to submit it to journals and get it published. Okay.
Thank you, all of you. Congratulations to all the winners, and congratulations to all the 14 participants who are attended, who did the wonderful work through this COVID time. All the presentation was very nice. Okay, now I would like to say Nirali to give the vote of thanks.
Good evening and congratulations to all the participants and the winner. As Sir rightly mentioned that it was a great presentation by all of you all. Thank you, Sir, for the detailed insight on the topic of research in clinics with various examples and each situations for each participants. I think it was a great learning for all of us today. Firstly, I would like to thank our IIP technical team for a continuous backbone. Otherwise, I don't think we can go ahead. Knowing that today is our 50th webinar since the last 5 months. So thanks a lot to IIP technical team. I would also like to thank all the committee members of Maharashtra state team, National Head Dr. Ruchi Vashne ma'am and Dr. Sanjeev Jha as well. Last but not the least, all the participants. Otherwise, I don't think we can take ahead a platform like this. So thank you, all of you. And a request to please fill up the feedback form. Link is being posted. So request to please fill it up. Thank you. Have a good day.
Thank you. Thank you all.
Thank you, sir.
Thank you all the panelists also. Thank you very much. Thanks for the opportunity.
Thank you. Thank you, sir.
Wish you all the best. All the best. Thank you.
Thank you, sir.